This is a 60-year-old female with a history of corneal ulcers bilaterally. We're starting off the case with marking the corneal center. We use a caliper that's preset to about 7 millimeters to draw some inkless marks on the cornea. Then we mark the center with a gentian violet pen. Because we're planning on doing an extracapsular cataract extraction open sky, in this case we're mounting a Fleuringer ring. We use an 8mm tree fine that we've preset. We apply suction, we wait for the suction to engage, then we start rotating the spokes, first off until we get the tree fine back to the epithelial plane, and then for about 2 full turns, which equal 500 microns depth of the trephination site. We sometimes perforate, sometimes not. In this case we didn't. We open up the trephination wound with a diamond keratome, and then we fill the AC with dispersive viscoelastic. We then proceed to cut the trephination groove with scissors to the left. We continued this for the whole peritomy of 360 degrees. It's important to be careful when doing this, because the architecture of the trephination site will dictate an important part of your astigmatism. So when the cornea is clear like this, it's pretty straightforward not to engage iris or damage it or damage the lens, and also when there's no pressure. This case is one of the friendlier ones. So as I was saying, it's very important to have vertical margins to your cut. This is why you mustn't rush this step. You should enter with your scissors horizontally, and then as you're starting to find the groove, hold them vertically so that the trephination site has vertical margins. This is quite important. Some surgeons, while reaching the end of the cut, leave a hinge of cornea to have a safeguard in case of an intraoperative choroidal hemorrhage. We didn't do this in this case. We then dry the AC and stain with trypan blue. We use any sort of sharp needle to puncture the anterior capsule, and then using non-tooth forceps we do the open sky rhexis. Now this step is of course very important. It feels a lot different than it does doing it on a closed globe. Vector forces are quite unstable. Sometimes they're very friendly, sometimes they're not. You also have to be very careful when resting your hand on the patient's forehead not to touch the speculum, because this will change the intraocular forces. Then we go ahead and do the hydro dissection, which most of the times expresses the nucleus in whole, with an important part of the epinuclear shell and the posterior cortex. We then go ahead and wash out any cortex that was floating around, and we proceed to aspirate the peripheral cortex. Now, in this case, we should have done it with irrigation aspiration on, but it wasn't on hand. So what ended up happening is that we pulled on the posterior capsule and made a rent. But in this case, just pulling on the capsule did not break the anterior hyaloid, so we have effectively no vitreous prolapse. We stop, we leave the residual cortex as is, and implant a 3-piece MA lens. Now we see that we've gone into burger space with the leading haptic, so we pull out and change the site of implantation and push towards the sulcus. Now we see that the posterior rent is still round, so we know we're in a good plane, and we'll push the trailing haptic into the sulcus. Now the cornea has been cut, and we lay it on the surface on a bed of viscoelastic. It's important to place viscoelastic all over in the AC and on the corneal rim, because most of the time your cornea is going to be rubbing against the peripheral rim of the host. So you want to have viscoelastic in that side as well. Placing the 12 o'clock suture sometimes requires, it's not necessary, but it helps to have Pollack forceps, which is a colibri with symmetrical teeth which you pass the needle in between of, that means that the cornea will not torque significantly whilst passing the suture. And that's quite an advantage for some of the tougher corneas, like the pediatric corneas we sometimes get. Those are quite rigid and elastic, and it's quite difficult to pass the suture through them. The 6 o'clock suture is said to be the most astigmatically significant one, and of course that is the case. So it's always best to pay close attention to have as much cornea on the right side as you do on the left, so as to find a good balance geometrically between the two sides. Now, in terms of sutures, this is surgeon preference. What we do is 3-1-1 knot. Sometimes locking the first three, other times not so much. It depends on the day, the surgeon, and basically what you're comfortable with is good enough. As long as you have a good knot at the end, it really doesn't matter how you get there. And a good knot means enough tension, but not too much, and good wound apposition, meaning that you're as deep in the host as you are in the donor cornea. And then not over tightening and not under tightening. Of course, you can always go back and redo these sutures anytime you're not satisfied with the way they look. You should always go back, especially if we're talking about the cardinal ones, like the first 4 sutures. These are the most significant in terms of astigmatism. So if one of them is not as you would like it to be, you should replace it on the spot, because all of the subsequent sutures that you will put will reflect and will exacerbate the astigmatism that you've created in the beginning. Now we have the 4 sutures in place, and we don't like the one at 6 o'clock because we feel it's not radial enough. It looks like it's a bit to the right centrally. So we just remove it and replace it. It's better to replace it sooner rather than later, because the impact on the astigmatism is greatest at this point, before other sutures are in. Now moving forward, after the first 4 sutures, in a PK, you have to put the next 4 in as well if you plan on doing a running stitch immediately. It's not wise to start a running suture after the first 4. You should do it after the first 8. You can start a running stitch. Whereas in DALK, you can start a running stitch after the first 4. So what we usually do is end up using 16 interrupted stitches. Here you can see us burying the knots. We routinely bury them in the donor cornea. Sometimes they won't go in, and we rotate them the other way. But at the end, they should always be in the donor graft. Subconch dexamethasone, and that's the case.